Today we're going to be talking about the significance of the will to live in the terminally ill and what this means for you as medical students. So we want to give you a greater understanding of the different determinants and motivations that affect both life expectancy and will to live. You should also come to understand how one's will to live may affect longevity in terminally ill patients, and you'll understand how improvements in standards of care and communication with patients can improve their quality of end life. So firstly, I just want to talk about what the will to live is. It was actually first defined by Arthur Schopenhauer in 1883, who was a philosopher. And this is thought to have foreshadowed Darwin's theory of evolution, as he himself mentioned this in his book The Descent of Man in 1885. But in psychology, this had to be adapted slightly, and it is a drive theory for self-preservation, usually coupled with expectations for future improvement in one's state of life. However, obviously this is quite a difficult subject to talk about when we're considering that people may know that they are going to die as a result of their diagnosis. So here we're looking at what determines terminally ill patients' will to live. There've been very limited studies that specifically examine the issues of the will to live per se, but a few of them have addressed them with constructs that may serve as its proxy. So some studies using responses to hypothetical scenarios before and after treatment have documented the extent to which treatment of depression actually influences a patient's desire for life-sustaining therapy. Other studies have shown a strong association between interest and euthanasia. And when you use this euthanasia as a proxy for one's will to live, they found links between this desire for euthanasia and depression. There's an increased sort of link between this and pain as a determinant and other distress and symptoms. As well as the severity of the symptoms, we need to really think about multiple areas of the life, whether involving physical state, mental state, or wider environmental factors.
So now we're going to focus on conditions, starting with social. So we've got social class. For example, the more elite would have access to private healthcare, including therapy in such retreats. Some would argue that overall a better quality of life, potentially resulting in higher optimism. And then we've got Bourdieu's capital. Bourdieu highlights the importance of capital beyond finances. He talks about capital wealth in regards to the 8 forms of capital. As you can see, then we have intellectual capital. The more intellectual, the easier it may be for the individual to communicate with hospital staff effectively. Then there's social capital, your family network, your social network, and even your acquaintances. The more people you have supporting you, the better your will to live will be. Then there's spiritual and cultural capital. Spirituality and religious beliefs and cultural norms and overall attitude towards life are also big determinants. If someone believes in heaven or life after death, for example, they're going to be more accepting towards death. So I'm going to dip slightly into the environmental and the age and the cultural side. So 77% of Western European populations said that they would not take a pill that would make them live forever, nor would 55% take a pill that would give them an extra 25 years. It has been suggested that this is due to the negative perception that comes with old age, whereas places like Malaysia, India and China have a more positive view on aging. Moving on to environment and historical improvements in healthcare, the link provided in the reference list, it'll take you to a timeline dedicated to showing the driving improvements from 1986 to 2018. Advances in healthcare can only be a good thing, can't it? Not in America, where the problem of death is widespread and focuses on the cultural ideal of death with dignity.
So just following on from that, in 2015, researchers at Stanford University called for more healthcare providers to take emphasis on the importance of individual mindsets in social context and healing. And over the past decades, increases in life expectancy in modern societies have raised the questions about whether and to what extent individuals value possible extensions in their lifetime and how this can be used ineffective care in patients. Recently, Lang and others looked at 3 mindsets that are common in research, suggesting that these mindsets are not separate entities but embedded in individual belief systems, attitudes and behaviours when considering late life preparation. And for the purposes of this presentation, considerations towards end of life preparation. You can see the 3 mindsets, and on the right, you can see the possible presenting issues associated with a particular mindset. Up there at the top, the essentialist view is that age is an inevitable and undesirable process. It's common in this mindset for individuals to look in some way, shape or form to push back the aging process. They'd be more inclined for things like plastic surgery. Next down, we have the medicalist mindset, and that's something that we'll look more at in more detail next, and that with regards to at least communication. The issue here is that an individual's will to live relies heavily in maintaining a functioning health, preferring to avoid the vulnerability of illness, old age, end of life, etc. Common in this mindset is the lack of the will to live if health or health functioning can't be maintained. The Stoic mindset, last on the list there, is an attitude that on the surface looks to be the more positive approach of the 3. And we'll look at an example of that at the end of this section. However, positive on the outset, the reality is that an individual's condition may be overshadowed by the need for a sense of meaning in life. I'd like to focus for a moment on the medicalist mindset and Groupman's work when it comes to communication and considering that for yourselves and for your patients. Groupman stated that we all have a medicalist mindset and that we fall into one of the 3 groupings on the left. The groupings are quite self-explanatory, but very briefly. So the maximalist there at the top, maximalist, favouring medical intervention first, whereas the minimalist, obviously, would look for that as the last possible option. Next down, the believers have a kind of blind faith in any medical intervention, whereas the doubters would delay possible treatment regardless of how important it is. And lastly, we have the technologists, who are probably more agreeable to evasive interventions, medical interventions, whereas the naturalists would look at more herbal, natural approaches, an individual preferring talking therapies over antidepressants, for example. So just returning to Lang for a moment, it's important to note that there is more than just one possible mind frame at play in interacting with each other. When caring and communicating with patients, possible attitudes and behaviours such as stress, anxiety, denial, that they're understood by yourselves. For example, if an individual displays an essentialist mindset, who would also be a doubter by Grupper's terms, then they would need extra support rather than just being passed off or being seen as negative or non-cooperative. The last thing I'd like to look at in this section is a good example of the Stoic mindset and its benefits. I'm going to use a population rather than an individual, but it does tie in. I'd like to focus on the research conducted from a Japanese island in Okinawa. Okinawa is famed for having the longest average life expectancy in the world and the largest concentration of centenarians, those who are 100 years and over, in the world. Taking into account other research, such as on diet and environment, they found that a key factor was something called ikigai. Roughly translated, ikigai means lifelong purpose or having purpose. Not having enough time to go into it fully, ikigai is exactly that, giving people dignity and purpose in their old age. In many respects identical to Csikszentmihalyi's flow theory with regards to purposeful and satisfying activity. You can also see there, a little bit down, that the percentage reductions in illnesses in that island are huge. Most notably there, you see at the end, is 80% in breast cancer. So, as we saw before, communication and capital, it's important to look at the whole picture, not just about one separate thing. An understanding of a patient's social capital, if you like, is as important as the medical interventions themselves. And that's something that you need to be aware of when dealing with your patients.
Evidence for a link between the will to live and longevity in the terminally ill. Orne et al. 2020 produced a study assessing the will to live in terminally ill patients receiving palliative care. A numerical scale was created scored between 0 to 10 for the intensity of the will to live, 0 being very little will to live to 10 a very high will to live. This study provided results stating that the will to live in terminally ill patients was very high, with a mean of 7.9 on the intensity for the will to live. Greer et al. 1987 created a study on the will to live and its effects of outcome after diagnosis on 69 female patients with early-stage breast cancer. The study findings showed that the women with greater will to live and a fighting spirit were more likely to be alive and cancer-free 5 years after surgery to remove their cancer, more so than the patients who dealt with the news of cancer with hopelessness. A further study of this group 10 years later confirmed this report. A study in 2019 by Ali Munjang et al. On advanced stage ovarian cancer patients with 5 years life expectancy showed that 30% of the female patients exceeded this expectancy. The research collected from the patients gave the results that a strong will to live, whether it was to spend more time with loved ones or reach a goal achievement, was one of the main factors which added to their longevity. Illusions in terminally ill patients. Beadle et al. Created a study of 149 patients receiving palliative care with 3 months to 2 years lifespan, with illusions of diagnosis and a will to live. Out of the 145 evaluable responses, 27% had the illusion that their cancer was curable. One of the reasons for this belief is the will to live and the belief that they are the exception and will beat the cancer, a fighting spirit. Clavarino et al. Created a study to assess the impact of the will to live and the belief in curability with 46 terminally ill patients. The study was split into 3 meetings for each participant. The first meeting was 2 weeks after diagnosis of the incurable cancer. The second meeting was approximately 3 months after the first meeting, and the last meeting, which was within 8 weeks of death of the patient. The results provided by this study showed that there was an increased will to live among the patients at a 41% increase between the first and second meeting. This figure dropped dramatically between the second to third meeting to 20%. A similar pattern occurred when the belief in curability going from 27% increased in curability between the first and second meeting to only 5% in the third meeting. This is believed to be the time when patients accept their diagnosis and fate. This could be related to increased pain, increased disability, functional limitations, and a decline in well-being. How your communication with patients can improve their well-being. If you look at the first example, the implication of the cancer spreading and behaving like this is that it really cannot be cured with treatment. Delivering the diagnosis factually, as stated in the example 1, is believed to push the patient into facing reality so that they are able to make the most appropriate decisions regarding their treatment and their future. In example 2, the doctor. The point is, we do not regard it as being curable with chemotherapy or radiation treatments. And that's no reason not to have treatment, but it's just a reason to say that the future is very uncertain. I think that in the longer term, this will catch up with you. This form of delivery could be misinterpreted by the patients and participate in their illusion for curability. There is an increasing body of knowledge and research appearing which states positive illusions are a good coping mechanism and for well-being and traumatic times.
In order to understand the patient's need throughout the end-of-life stages, It said that there's to be 7 elements to which people have said to define it as dying a good death. And the first is of awareness of the illness and the way that medical staff portray the condition in a way that the patient's able to understand, and as they become more accepting and aware of the condition. Hope links into this through being a key element throughout all the stages. By using an adaptive communication style, it can create a belief within individuals of life after death, which then lessens the will to wanting a hasten death. Pain management becomes key within the comfort of terminally ill patients, as well as being able to maintain the mental state. And by allowing patients to have an input on the decisions of the treatment and care. In those who found connectedness within a support system or within caregivers, it also allowed them to accept diagnosis, although connectedness also came back the link into the comfort and hope. So just to conclude, you should now have an understanding of a huge variety of determinants of longevity and the will to live within terminally ill patients, and how this is perceived across different people in many circumstances. And we've shown a link between the will to live and how this affects longevity to give an insight into factors in end-of-life patients. And you should now be better equipped to consider how you communicate as clinicians and provide end-of-life care which can genuinely change lives.
If anyone has any questions, please let us know.